No. Can I take a piss first? I'm going to take a piss now, right? Simple.
Coming, guys. Ooh. Hey everyone. Oh, hello. Is it working? Hi guys, thanks for coming. Can you hear me? Can you hear me? No. Hello? Hello? Not working? Oh, this way? I don't know what. All right, hey guys, thanks for coming. Is the mic working? I really can't hear it. This mic. No, whatever. Not too sure. What was yours? Do you want me to introduce?
Can you hear me? No? It's up full. Oh, hang on. Here we go. Hello? Is that better?
Sorry about that.
I know. Yeah, I don't know.
It's really annoying.
That's as high as it goes. That's fine. Yeah. Can you hear me? All right. No, not really. All right, I'll just speak louder. So I'm Luke. I'm one of the interns currently at Monash and staying at Monash next year. And I am talking about financing and stuff like that. This is obviously a new topic for all of us, given we didn't study accounting. But hopefully this will give you some advice and helpful tips. It should be relevant to everyone, regardless of where you're working. But obviously, there's a few sort of Monash specific things within this, and we can answer any questions at the end if you've got any. So the three main things I'll talk about today are obviously pay rates and hidden extras, because commonly the people in the payroll office at your health networks are quite useless and stuff up quite a lot. So it's good to be able to catch them out and feel great about it. Second is salary packaging. So again, relevant to everybody, but with minor differences depending on whether you work. And then tax time and just some tips for making sure you get the most money back at tax time. Obviously, disclaimer, I'm not an accountant, but I think you should definitely all get an accountant. They can be very useful. They keep you on track and obviously maximise your savings and benefits at tax time. And a lot of the people you either already have met or will meet next week offer sort of all-round services, not just to do your tax return at the end of the year, but also, once you get looking into sort of buying houses and things like that, they're really useful. And the third thing is that I've stolen some things from the Maxia website, which is the main salary packaging firm that most of you guys will belong to, but I'm sure they won't mind. So in terms of pay rates, to start things off, every single hospital in Victoria, no matter where you work, are all governed by this AMA agreement. It's in its last year, so it's currently being discussed at higher levels about potentially getting us some more money and rules and things. But everyone is governed by this. So if you really want the nitty-gritty of, you know, whether you've been harshly done by or your rosters are incorrect or you think you're working too many hours, this is the place to find it. So in basic terms, everyone's hourly rate is $33.53, which is a hell of a lot more than all of you are getting now. You will be rostered for a minimum of 76 hours a fortnight, and depending on which rotation you work, that may be more. And so at a very, very basic and standard rate, if you calculate that, you should be getting about $2,500 a fortnight, which is the most I would think most of you have ever received. And that would mean that if we went on just that base rate, you guys are all entitled to at least $66,000 next year. I was expecting more woos. However, overtime, which again, very dependent on the rotation that you work, but most will have some form of overtime, penalty rate, or added extra. So if we bank on getting 76 hours every fortnight, and that's what our contract receive, that will be that $2,500. For the first 2 hours above this 76-hour bracket, so if you work a total of 78 hours in that fortnight, for those 2 hours, you then get $50.30, which is 1.5 times that rate. And then for every hour beyond that, you will get $67.06, which is very exciting. I put in that picture on the right there. So for people working at Monash next year and most other places, they do also offer these rates when they're very much in trouble. And as you can see there, they are well above that overtime at about $95, if you can read that. Some of those shifts go up, that's better, yeah. Some of those shifts go up to about 14-hour days. So if you times 14 by $95, that is quite a lot. That's better, I like it. So when we talked about that base rate before and obviously overtime, depending on the rotation, some, or should I say most rotations would only give you the 76 hours because obviously it's the cheapest thing for them, but many don't. So for example, I just did colorectal at Monash and we were rostered for 51 hours a fortnight. So if you calculate that's 102 hours a fortnight. It's quite a lot of overtime. So in terms of penalty rates, which is something you should all be aware of because they can often forget to pay you this. So you need to be on top of it. So from a standard working day, so anywhere between 6:30 a.m. and 6 p.m., you'll be paid that normal hourly rate of $33.53. If you work a weekend shift, so this is anything from Friday midnight to Sunday midnight, you should be paid 1.5 times. For night shifts, so that's any shift that crosses midnight or a shift that starts between 12 a.m., so midnight, and 6:30 a.m., you should get 1.25 days. So we're quite lucky in Melbourne because we have the Melbourne Cup and we have the newly introduced Grand Final Eve, which is the best money dinner in the world, but great for you. 5 times. And the beauty of being in full-time work is that if the rostering guys decide to give you this public holiday off, you still get paid. So you still get paid a standard rate of $33.53 for an 8-hour day work. So you can sit at home drinking beers and still get paid. Evening shift, so that's any shift that finishes after 6 p.m, irrespective of the start time. You will get this little bonus of 2.5% of your week of the standard weekly rate, which is $2,549. So you'll get an extra, hang on, that's not right. It should be about $30. That's all right. It's about $30, trust me. Meals, so if you work any shift more than 11 hours, $85 to go and spend at Zuki. And then you get this great thing called CME. So They call it an allowance for your education, and you just get it paid just because. You don't have to spend it on education. You don't have to prove that you spent it on education. They just give it to you. So you get $40.30 per week for no reason. Other optional allowances. So for those of you who get a rural rotation, you'll get a travel allowance. So every rural hospital site, aside from Mildura, you will get an added benefit of the value of a first-class rail ticket every 3 weeks, for whatever that means. And if you're placed in Mildura, you will get a return airline ticket every 4 weeks. A location allowance is also given. So when you're at a place that is again rural, so think Warragul to Railgun and things for the Monash guys, or everywhere else for everyone else, you get $40.49 per week just because. Conference leave. So if you decide that you want to go to a conference, you don't have to be presenting, but you just have to be going, and you can prove what days you should be going for. They will pay you to go. So you just take a week off work, you go to a conference, and they will still pay you. And then finally, annual leave. So every single intern in Victoria has 3 weeks off in January 2019. Plus you will get 2 weeks during your ED term, whenever that may be, when you find out your roster. That is what you're entitled to. So the next slide I'm putting in, just because it's a question that I'm sure you all want to know, which is how much do you actually get paid? And I'm just going to put it up quickly. But as you can see, it is not anywhere near that $2,500 a fortnight that you're supposedly getting. Obviously, this is very dependent on rotations. I've been lucky in that I've got quite a few rotations this year that have paid overtime. But as you can see there, there's nothing that even Kingston Rehab is well above the 2,549. And that's the lowest one I got. And you'd be like, why did I only get paid $1,100? And you wouldn't believe, but you guys get paid to go to orientation week. So you sit in this similar lecture theatre. They tell you about how your health network works, and you get paid $33 an hour to do that. So after 5 years of med school sitting in lectures, it's the greatest. The one thing I'll point out, which brings us to our next topic of discussion, is if you see the two that I've highlighted, they're both quite similar gross salaries for that fortnight, but the tax is very, very, very different. And you may ask why, and that is because of salary packaging. So I'm going to use a little... Oh, no, it's not going to... Oh, is there some way we can play the sound? Nah. I'll start. So this is obviously from Maxia. Sorry, Maxia, but it was good.
Here's how it works in a nutshell. Normally, tax is taken from your salary before you spend it. You then pay all your expenses and have a bit left over. Let's rewind and pretend you now have a Maxia salary packaging account. Your employer still pays you the same salary, but now we help you pay those same expenses before tax, which means your total taxable income goes down and your disposable income goes up. Right now you might be thinking, what's the catch? There is none, because it's all 100% tax.
Important.
Exactly what you can claim depends on your employer and other circumstances. So give us a call to find out.
So that is salary packaging in 45 seconds. And it's all ATO approved. So, as they pointed out here, and it's quite hard to get your head around it. Oh, you're getting many messages. Sorry, I'll turn it off. So the little picture there on the left is probably the easiest way to explain it, which they explain in the video. So normally you get your pay. So this is your gross pay. So if we use that $2,500 that you should all be getting paid next year, from that $2,500, the government takes out tax, and that is the same tax that any other person working any other job would be taxed. Then you could go ahead and buy your weekly groceries, pay your rent, all of that, and that's all you have left. With salary packaging, which is eligible to every person working in a public hospital in Victoria, so i.e. all of you, you can get your pay, so say you're $2,500, you can then pay your rent, pay your groceries, etc., which may bring it down to, let's say, $2,000 a fortnight, and then they look at that $2,000 as the amount to be taxed. So instead of looking at your salary going, you've earned $2,500, we take tax from that, they'll look at you instead of saying, you've only earned $2,000, so we'll take tax from that. So obviously, it will be less tax to pay. So on the right here is, again, from Maxia. Thank you, Maxia. Should be a rep for them. You've got your gross salary, so I've just set it at approximately $80,000. With salary packaging, you should end up with about $53,000 of disposable income to do whatever you want. Whereas without salary packaging, you would end up with about $49,000, which means you save about $4,000 per salary packaging year. So it's obviously worthwhile doing it because an extra $4,000 in your pocket is better than the tax man. This is a bit more comprehensive breakdown of how it actually works, but I think it's quite relevant and useful way of looking at it. So again, if we start off with that $80,000 as your yearly income, with salary packaging, they will take out your predefined spendings and you'll end up with this. So when the ATO look at your salary, they'll say, oh, you've only earned $68,000 this year, as opposed to you've earned $80,000. So you can see how much they'll charge you for tax is $19,000 versus $15,000 because they're obviously looking at you only earning $68,000. Then if you bought the same amount of, groceries, rent, whatever, this is how you would end up. And that's where we get that number of about $4,000 saving. In terms of what you can package, this is just some examples. This can be different depending on the health network that you work at. But as a general guide, this is what you can use. So you get $2,500 of meals and entertainment per year. This can be any cafe or restaurant that you ever go to, where at least some of the items have been food. So you can't go out and spend $1,000 on the bar tab and claim that, unfortunately. Maybe if you buy some food or snacks with it. Also, you can do work-related travel or accommodation, holiday accommodation or venue hire. So if any of you are getting married or you want to throw a big 25th birthday or something like that, you can claim. The other $9,000, the big one I think for most people in this room is rent. So as long as you have a rent certificate, so something to say you pay X number of dollars per week for your rent and it goes for 52 weeks or whatever your certificate is, you can claim that. Now, depending on the health network that you work at, this changes a little bit, but certainly for Monash, they let you use this year's rental certificate as that claim. So if you want to use your final year medical student rental certificate, you can use that. And if you work out $9,000, that's about $175 a week. So anyone who's paying roughly about $170 a week on rent, that is your $9,000 already done tax withheld. For other places, I know there's other health networks that have an unlimited time period on your rental certificate. So you could use your first year rental certificate if you wanted to, and they will take that. Other things you can use is credit cards. So if you've got some sort of debit or credit card and you get a monthly statement, you can claim that back to use some of this $9,000. Bills, so electricity, power, whatever you want to do. Financial advice, you can also put under that. And then these other weird and wonderful ones like airport lounge memberships, if you're into that, health insurance, AMA memberships, self-education, etc. The reason why I think it's important to tell you all this now is because it's actually very important that you get onto it as soon as possible. And I will get to the reasons why. So the salary packaging year is the 1st of April to the 31st of March. So obviously when you guys start working mid-January, you're already well into that 2018 year, and you obviously only have about 3 months left of that year. But that means that you can spend that $9,000 and $2,500 within that time period, and it will all be tax-free. So then you'll move into the 2018-2019 year. and you get another $11,000 of use. This is the first and last time you'll ever have access to this, because obviously from next year onwards, you'll be working full time, and so you will always be having a year worth of salary packaging. So if you look into, this was obviously my paychecks up until that 31st of March date. So if you work out that, that's about 4, 6.5, 10.5, 14. So out of that sort of $16,000, $17,000 that I earned, that means 11,500 of that was tax-free. So looking at this, I only paid about $600 tax when I earned $16,000, which is very useful. So that's the reason why you guys should get onto it as soon as possible, because you don't want to miss out and only start being able to claim this sort of paid back, you know, halfway through February, because you've kind of, you know, you need to be earning enough to claim it all back. The other reason that it's important to know how to do salary packaging properly as an intern is again because of this salary packaging year being a bit different to financial year. So salary packaging year, as I said, is 1st of April to 31st of March, whereas the financial year, that's the one that most people talk about, is the 1st of July to the 30th of June. So if you think about it, that in the 2017-2018 financial year, which is the one that you guys will be entering in January, you'll earn, if we say that you earn about $80,000 a year, that means you would earn about $40,000 between January, when you start, and the 1st of July, roughly. Whereas after July next year, you'll be within the full financial year and you'll get yourself to, you know, $80,000 or so by next July after that. So if you're going to make the best use of your salary packaging for this, you want to reduce your taxable income. If you look to the right there, that's how much every Australian gets taxed on their income. And so as you can see, the more you earn, the more tax you'll pay as the tax brackets go up. So after this amount, you start paying 32.5 cents for each dollar, 37 cents, 45 cents. So ideally, you want to keep yourself in the lowest tax bracket possible. So I've made a little graph here as to how you should best do it. Obviously, this is when you guys are starting in January. This is what you've got left of the 2017-2018 salary packaging year, and then you'll continue on in the new year like everyone else. Whereas this is the financial year, which you guys will earn roughly $40,000, and then move in from the 1st of July next year into the 2018-2019 financial year and earn about $80,000. So it should be a no-brainer, but it is difficult the first time you look at it, that obviously the tax bracket that you want to be in is this year, not. Does that make sense? Getting charged the least amount of tax per dollar. So in this tax bracket, you're obviously paying a lot less tax per dollar than you are in this one. The difficult thing with this is obviously you've got this added bonus that you've got all this salary packaging money that you can use before the 31st of March. And so you'd be stupid not to exploit that. So once you've done this, you've taken your $11,000 of goodies that you can get, actually stop salary packaging after this date, because you're only going to earn $40,000 this year when you start working. And so when you get to tax time, taxable income only be $40,000 here and not use your salary packaging than to use it all here and not use it here. Make sense? Exactly. So depending on where you're working and which provider you'll use, each health network has their own designated salary packaging company. So most people are Maxia. If you're at Austin, it's Austin Advantage, and there's a couple of different others. Yeah, all you need to do is call up a couple of weeks in advance and say, hey, I want to stop it from the 31st of March till the 1st of July. they're very well aware of it, because obviously the smarter you are, the more people that will do it. So if you call up and ask for that to be stopped, then they just stop it and then restart it after that. You have to tell them how much to take out, but all you need to do is really calculate what this 11,500 is by 9 months, because obviously it's 9 months until the end of that year. So if you say 11.5 divided by 9 months, then you can work out how much needs to come out. Any other questions? Yeah.
11.5 is quite a lot to spend in that short amount of time. Last rent. I don't understand how that works. Like, where the money goes if people are
Sure, yeah. So it's a hard concept. Way is, it's like they're willing to pay you. You just need to prove that you have spent it on something. So it's a hard concept to understand, but essentially what they will do, the easiest way to think about it is the bank account of your money. And so every paycheck you get, amount of money will be sent from, say, Monash Health to these guys to hold. Once you can prove that, like, yes, I've spent some money that's related to work or whatever, give you the money to take back. So with the rent certificate, you're giving that to them to say, I've spent my $9,000 on salary packaging. Here it is. Now can I have my $9,000 back that you've kept as a pre-tax income? Yeah. Yeah, a little bit. So as I said, for most people, and that's what I've done, is the rent, because you put that down and then they're like, sure, okay, your $9,000 is redeemed. You'll get that back, you know, $500 a fortnight or something like that, depending on what you set it as. With the meals, so some places have meals and entertainment cards. Maxia gives you the option. They really try to force the card on you. Personally, I don't like it. Because Maxia allows you just to take a photo of your restaurant receipt and you just upload it in 10 seconds and say, I spent this much on this date. Here is the proof, and they refund it to you. So they take, say, $200 a fortnight. You put up your bill for $100 and say, look, I've spent $100. Can I have it back now? And then they'll just refund it to you. So personally, that I think is an easier way than getting a card out, because a card doesn't work at every place. It doesn't work at Zuki, etc. So, yeah. Any other questions about salary packaging? It is, yeah.
What if you don't spend the full 11,000 in the first month today, but they don't keep it?
Yeah. So if you, do you mean like in that first 3 months? Yeah. So you've got to. It goes over. So if you ask Monash or wherever you're working to take enough, which means that the full $9,000 will be taken by the end of 31st of March, that will stay in the little Maxia bank account until you've got enough like spending to redeem that back, but it will stay in the account.
Over the 31st.
Yeah. Yeah. Yeah.
That's not ideal.
Well, it's more that you make sure that Monash are actually sending the right amount of money to them. Because if you only get onto it mid-March and you say, oh, Monash, can you please send, you know, $1,000 per pay to Maxia, and you've only got 3 pays left, then they've only got $3,000. The problem is obviously you can't ask Monash to send more money to Maxia than what you're earning. So if you're only earning $2,500 per paycheck, and you're asking them to send 3, well, obviously they can't reach that number. So if you only, as I said, I earned about 16,000 in that time period. But if you missed, say, 2 or 3 paychecks, you literally could not get enough money into Maxia within that time. And that's when they cut off, because they can't send any more than what you've asked them to do. Any other questions before I move on? No. So just the final slide, and this is just kind of a general vague slide, but I think for tax time, get an accountant. I've seen people who try and do that themselves and you end up missing some things, and I think it's nice to be signed off by an accountant that you're doing everything right and that going into the future, you've got everything set up. It's quite easy as an intern because you've got a very easy tax summary to do. You know, in that you've only earned for 6 months, you've only got one employer, everything's fine and easy. But obviously going into the future, you know, some of you might start doing locum shifts at different hospitals. You might start doing, you know, doctor on call, weird stuff like that. You might begin to house market shares, investments, things like that. That's when they really become important. That's when they can definitely advise you on, you know, the best ways to save tax and things like that. You keep your receipts. So anything really that you've used since the 1st of July this year, you should have. So if you have done things such as bought a new phone, a new laptop, a new Apple Watch, a new Samsung Galaxy, a new anything, you should keep the receipt for tax time. Other things that you can claim at tax time, because you can say, yes, I use it. To be honest, you actually do use it for work, so you feel a little bit better about it. Internet use I don't feel good about, but they say why not do it. So at the particular account that I go to, it says, yeah, you use about 70% of your home internet for work, don't you? I was like, yeah, sure. It's mostly Facebook, but that's fine. Stationery, so if you buy anything, so even like home desks and supplies, printers and all that sort of stuff, you could say, yeah, sure, I print out my ward round lists at home. No worries. Conferences is the big thing. So if you go to a conference, make sure you collect everything with it. So the flights over there, the accommodation there, any transport, Ubers that you had to use, meals whilst you were there, things like that, you should all keep. Keep all your registration stuff. So for APRA, working with children's, because they're quite significant and costly, as I'm sure you're now aware. And so that can come off your tax bill. And then, as I said before, new phones, laptops. Somehow I got my Apple Watch through. That's fine. I don't use it for work, but that's fine. But they let it through. So that's why it's good to have an accountant, because they pick up on these sort of things. And they often prompt you and probe you as to like, have you bought this? And you're like, oh yeah, I actually have. So they're very good for mining, that sort of thing, and can save you a lot more money than what they charge you. And finally, you will get a very, very good tax return as an intern, because provided you have played your cards right, you've done salary packaging properly, and set up everything correctly, you will get a very nice tax return. Because obviously, if you earn approximately $40,000 minus the salary packaging $11,000, that means you've only actually earned, according to the tax man, you've only earned about $28,000 by the 1st of July. At a rate that would be equivalent to 80,000. So by the time you get to tax time, you've paid a lot more tax than what you should have been. And so your tax return is about plus or minus $5,000 in the 1st of July. These are just some accounts on the right. I won't say which one I use, but I use the one at the top. I've heard decent things about all of them. And I'm sure they'll all throw themselves at you in the next couple of weeks. So that is it. Any questions? So there is, like, it depends how you want to do it. So there is a thing called novated leasing, which you can discuss with your salary packaging people. That means you kind of like lease the car and you pay kind of upkeep on it. I don't know too much about it, but that is an option, and they definitely try and convince you of that. The only other thing would obviously be if you're paying, you know, if you've bought it on a loan and you're paying back a loan, then definitely you could use that loan bill as claiming that $9,000. Anything else? Nope. Okay, I will pass on to Riley.
Howdy. Okay. So a few of these slides I was going to work on this evening, but I've had an especially spicy day on 33 South at MMC. I'm Riley. I'm one of the Monash interns doing medical year next year. Fluids, electrolytes, and insulin. So pretty easy. The answer is really just give normal saline in almost every scenario, with few exceptions. And we'll go through the exceptions. Realistically, when the exceptions apply, you won't be the one putting the pen on the paper, so it doesn't actually matter. When the nurse asks you about these patients, or you find that these patients are hypovolemic or hypotensive, and you're getting these sort of general questions that are requiring IV therapy, you really need to differentiate between whether you're actively and acutely resuscitating the patient, looking for a fluid shift, or whether you're looking to replace the fluid, which all sort of falls into the acute category, where you're going to be giving lots of fluid very quickly, or whether you need to maintain this patient on 2 to 3 litres in a general sort of 70 kilogram adult. And that would more apply to your surgical terms, where there will be patients that are fasting, or patients with small bowel obstruction or ileus, or sort of any other cause for the patient being ill by mouth. So, I mean, obviously, like, I won't go through the things that you need to resuscitate patients for. I mean, that's you'll either know them or pick them up along the way. I mean, you need to give fluid very quickly to patients that are dehydrated. You need to give patients fluid very quickly in sepsis. Common ward calls for hypotension. You often need to give fluid very quickly as well. You need to bring about a fluid shift in anaphylaxis, or just give lots of fluids. Metabolic emergencies like HHS and DKA, you flood the patient with fluids, you just give it, and it's all normal saline. All right, so you just write it, you give it litres, I'm talking about. Hemorrhage, you give blood. 3 types of things, sort of 3 types of fluid that you'll be giving. You'll be giving primarily crystalloids. Okay, this is your hypotonic, isotonic, sorry. Or hypertonic. Hypertonic is very niche, generally 3% normal saline or 7% normal saline in some instances. Again, you will never be giving hypertonic. I don't know about the other guys. I have never charted hypertonic fluid. You won't either. It's used for SIDH sometimes. I mean, hyponatremia is not something which is treated often with hypertonic solution. You'll see ICU consultants and general medical consultants. You'll see all of these guys not wanting to give hypertonic solution for patients with SIDH and hyponatremia. You treat it with isotonic fluid because it's hypertonic to the serum of the patient anyway. And in brain injury, I don't think any of you will do an ICU term. I don't know if any health services offer ICU terms for interns, not to my knowledge. You use it for patients with cerebral edema, intracranial pressure to protect the brain. Don't worry about it. Don't worry about hypertonic solutions. Isotonic you'll be giving the most of. Colloids, again, I haven't had the pleasure of putting my pen to paper on colloids this year. Limited use in resuscitation, depending on how your consultant or team leader was schooled. I've never seen it on both my ED rotations. I've never seen it unless the patient was, had a sort of florid ascites or decompensating liver failure, or they were trying to actually shift this fluid from an extravascular or third space. But anyone else seen it? I very rarely see colloids on the page either. It's all crystalloid. It's all saline. Blood. You will actually give a lot of blood. Never given it for hemorrhage. Only ever given it for anemia. You give blood to patients with history of ischemic heart disease when the hemoglobin is lower than 80, and you give it to other patients when it's lower than 70, as a general rule. But you'll see all sorts of variations. I mean, people get it for a hemoglobin of 90, but it doesn't matter. You give it for anemia, you give it for hemorrhage. So I've ripped this off the internet, but it was an interesting graphic because it demonstrates human plasma, isotonic normal saline, which has your 154 millimoles of sodium, which is a little bit above your serum concentration. And for that reason, you also have Hartmann's solution, or compound sodium lactate, which attempts to sort of better resemble the serum concentration. Comes with lactate. People worry that giving I'll compare sort of saline and CSL, which is Hartmann's, in a moment. But people worry about CSL. They worry because it's got lactate in it, you're going to put the patient into lactic acidosis, which is not true at all because it's lactate, not lactic acid. So don't worry about that. You can give as much of it as you want to acidotic patients. It doesn't matter. In fact, it's preferred to normal saline, and this is one of the reasons you wouldn't give normal saline, rather. 2 reasons why you don't give normal saline. One is hyperchloremia. As you continue to put the patient, you keep bumping up the chloride, you keep bumping down the pH, and the patient ends up in a metabolic acidosis. What's the other reason? Now, your liver failure, you give colloids. Easy. So don't worry. Again, don't worry about it. Still go with saline. And overload is the thing you have to watch for all fluids, including normal saline. So if you're worried about overloading a patient with normal saline, why are you giving fluids anyway? All right. CSL is not, so Hartmann's is not for resus patients. So when you have these acutely unwell patients that need as much fluid as quickly as possible, you don't want to be giving Hartmann's because of the potassium component, really, is the key reason. Because often in these patients, you don't know what the potassium is. So if you're going to give 3 litres of this, you're going to deliver 15 millimoles to their serum, which is potentially fatal in a patient with hyperkalemia that's arresting, or whatever the reason is. Okay. Sorry, I did scribble down quick notes, so I'm just going through them. Oh yeah, sodium chloride with glucose. So often they'll bump down the sodium chloride concentration when you're giving other electrolytes or glucose. That's to maintain the osmolality of the solution that you're giving. Generally for maintenance, the hypotonic solutions often come with glucose because the glucose actively diffuses and is used up. This is just the way you should think about it every single time. As I said before, when you get the call from the nurse, which is so often the case, about these patients that don't have IV fluid ordered or they're hypotensive, you need to do your fluid status assessment. And you need to, again, not something that's really within the remits of 15 minutes, but that's something you need to get on top of. And you need to decide whether you're resuscitating the patient with normal saline, in which case you give a 250 ml bolus if you think they are dry. Everyone gets it. You will not kill a patient with 250 mils. Doesn't matter what their history is. If they're dry, if you clinically make the call that this patient has a low blood pressure, is tachycardic, has clinical evidence of dehydration or whatever, or they're bleeding into their abdomen, in which case, you're in trouble anyway. But you need to give the 250 mils straight away. Don't worry about it. Just put it on the chart and do it. And you can keep going. You can keep going. In the oldies, where you've got to be a little bit more concerned about putting them into APO and overloading them, just ask for help a little bit sooner than you would with someone who's 30 years old, otherwise healthy, diarrhea and vomiting. You can go as aggressively as you want. You can just give them as much as you want, as quickly as you want, and they'll just weed out, and it's fine. You tend to give CSL, by the way, in that when there's GIT loss because it replaces other electrolytes as well. That's another reason why I use Hartmann's. Just use saline. You can use saline as well. You won't get in trouble for using saline. Use saline. Cool. Maintenance. 4-2-1 rule. You can use it for kids and adults. If you're not across it, it's 4 mils. What is it? 4 mils per kilo per hour in kids that are under. Again, kids, you're not going to be putting the fluid orders on for kids that are under 10 kilograms. So don't worry about it until a couple of years' time when you're doing pediatric training, if you want to do that, or when you're working in pediatric emergency. But it's 4 milligrams per kilo in kids per hour that are under the age of 10 to 20 kilos. You're looking at 2 milliliters per kilo, and then 1 for every mils. So if they're over 20 kilos, if they're an adult or child, you generally give 24, 25 mils per kilo per hour, and that'll constitute up roughly your 2 to 3 litres. The 3 major electrolytes are all 1 millimole per kilo per day. Sodium is 1 to 2. Just 1 is fine as well. Glucose, you need 50 to 100 grams per day. Don't worry so much. It's not a science that's adhered to, really. You'll see all sorts of variants, but that's generally what you need. Where were we? Oh, yes. So potassium. Don't have enough time to go through all the electrolytes. Most of them come in 10 millimole bags, with the exception of calcium and a couple of others. Calcium comes in 2.2 to 4.4 from memory, or something like this. Not 10, not a nice round 10. Generally, when obviously you're not going to be replacing electrolytes for someone who has too much electrolyte. So if your patient is hyperkalemic, don't worry about this. You need to be giving other treatment. But for these sort of guys, you can replace potassium with any electrolyte you want, and it's going to look something like this. You just go to your at Monash, it's prompt guidelines. Elsewhere they'll have different hospital guidelines. They're your best friend. Just go and look and see what you need to do, and just write on the chart, and call the medical registrar or ICU in this instance if they're critical or severe. Cruzy, you can give IV, you can give oral for potassium. One banana, interestingly, which I didn't know before I did this, is 12 millimoles, which is actually more than a slow K tablet. Go figure. Cool. So you just, so when you get this patient, there needs to be, this is what the fluid chart will look like. So for the first box there, we've got like a maintenance sort of Hartmann's CSL. You just put your 1,000 down, you put an 8-hourly bag, which is a maintenance bag, cruising. Next one is also a maintenance bag. You just give a bit of dextrose, fine. Don't use dextrose in diabetic patients. Obviously, that as well. The next one is some sodium chloride. Now, these bags, I don't know if you've probably seen them if you go to uni or not. I obviously didn't, so I learned this year. But they drop down the sodium component because they're adding in the potassium. Now, the nurses don't actually, when they go and get the bag, they don't actually mix the potassium into the bag because that would be way too dangerous for them to be doing. So what they do is, it's too dangerous for me to be doing, to be honest as well. Like, I wouldn't trust myself to measure out 10 millimoles of potassium, which is 390 milligrams, of potassium into the bag. So they come pre-filled. They're in 1 litre bags with 30 millimoles, or they're in 100 milliliter bags with the 10 millimoles in them. If the patient is hypokalemic, just give 10 millimoles. Just give 10 millimoles and do a VBG. Easy. And then you see what you've done. And you'll learn quickly that 10 millimoles of potassium through a bag doesn't really do much to the potassium. So you can do as much as you want, really, but just do a VBG. So you give you 10, you can actually give 30 if they're hypokalemic. Give you 30 millimoles, do a VBG. How are they tracking? Good, bad, more potassium? Yes or no? Easy. Super easy, this stuff. This is good. The last one is an example of an insulin infusion. Now, this is something that you'll give to diabetic surgical patients, patients with DKA, patients with HHS, and it is very guideline directed. So you go to the hospital guideline and you look at the DKA protocol and you see that you need to obviously flood the patient with normal saline. And while you're doing that, you give an insulin infusion, and I'll say you add 10 units of ultra short-acting or short-acting insulin with some potassium, because it drops your potassium, and then the nurses choose what rate it goes, depending on the blood sugar and how things are going. And then there are compatible fluids. You often give dextrose as well in fasting diabetic patients with your insulin infusion. So, fluids are pretty easy. Again, saline, push saline. This is, I think, a Humalog diagram from the website. And again, this is something that I wasn't really across when I started. Insulin can be a tricky thing. So we're moving on from fluids and electrolytes. That's really easy. That's just normal saline. So, or blood. This one here, so you got your 3 curves there, yellow, red, purple, dark purple. Dark purple, and you can get graphs of this to sort of like, so you can get your head around it a bit easier. The dark purple is your ultra short acting. So that is Novorapid, that's Humalog, and that's Apidra. Which the patient will might be on. That will wear off in 4 hours. You think it works immediately and then it just drops the blood pressure and then, blood sugar and then it's gone. But it lasts for 4 to 6 hours. It's in the sort of system for that long. But it'll start acting after like 15 minutes. So you'll see some improvement if you're giving the right dose. Then you've got your short-acting ones. And short-acting are the Act Rapid, which you obviously add to the insulin infusion, and things like Humulin and things that you don't really see very often. You see Act Rapid. Then you've got intermediate acting, which is the sort of red curve. That's like Protophane and another type of Humulin. Don't worry, you'll know it when you see. Just look it up. What is it? Intermediate acting. No worries. And then you've got your peakless basal insulin. That's Lantus. Lantus you normally give once a day. I've seen it BD, which is a weird dose, but Lantus you give daily. So it's part of like either just a basal insulin scheme or it's a bolus and basal. So it comes as either basal, where you just give Lantus, or it comes as Novorapid and Lantus, because they're still really poorly controlled around meals. Peakless, last the whole day. Start at 10 units-ish, and you can work up. So this would be your sort of prandial peaks in yellow. This is another one from the Humulin one. And so this would be a patient that is either not on basal insulin or might be on basal insulin, which is Lantus or Levemir. Levemir is another basal one. And you can see sort of obviously the basal dose drops the blood sugar around your meals. Okay, so that's pretty cruisy. This is your mixed ones. So in addition to those ones, in addition to your basal Lantus and your sort of bolus doses of Novorapid and these short-acting ones, you have these mixed things. So the mixed ones are like Novamix and Mixed Hard and Humalog Mix, and they often have like a 30 afterwards for the pen. That just refers to the amount of short-acting insulin in them. They're a mix of ultra-short or short-acting insulin, and they're a mix of intermediate-acting insulin. And you see the gold curve there, or the brown curve, is the short-acting stuff, and then you have or grey curve for the intermediate. So that's all those are. They are BD dosing, generally. Seeing them TDS as well. Endocrinology don't love TDS, but GPs sort of sometimes do it, which is, I mean, that's fine. They might work. That's great. But the curve should look something like this for the mixed BD, mixed pens, Mixed Hard, Novamix, etc. Key tips. Key tips. Every type 1 diabetic in the hospital needs endocrinology on the phone, at least. You should never withhold. In fact, you should never touch a type 1 diabetic's insulin without talking to someone else. If it's real critical, you can dose reduce. But if it's real critical in a type 1 diabetic, you need to be on the phone. You should take ketones in patients, whether they are type 2 or type 1 diabetic, doesn't matter what they are. If their blood sugar is high, just get the nurse to do the ketones as well, because you want to know what you're treating and how urgent it is. If it's 10 to 15, you could probably get away with it. But anything above 15 should probably have ketones. Type 2 or type 1. Couple of other tips. When you're treating patients that are on oral hypoglycemic therapy, and they have, and this is frequent, this happens all the time, and you're not brave enough to start some regular Lantus, which is fair enough. You could start regular Lantus. We'll go through what to start and when. But you just give Novorapid. Just give it you can even just give 2 units and see what it does and watch them over a couple of hours, get the nurse to repeat it in an hour and then in 2 hours and see what you've done. They say, oh, great. And you just do that once for your first diabetic patient. And, it's obviously a big thing when you're writing it on the thing with your name. You just do that once, see what happens. And then everyone else that comes afterwards that's insulin naive, you'll be super cruisy and you just do it every time. Don't do sliding scales. You want to act like when you're treating these patients with diabetes, there comes a point where you need to self-promote a little bit and be able to say to your registrar, as long as it's not dangerous, that, look, they're on all this insulin. I sat down, I thought about it. I called the endocrinology registrar. we're not going to, I wasn't going to give a sliding scale. We started the patient on Lantus because it's 1 injection as opposed to 3 or more. And it's, you know, it's a better long-term solution. So you need to take a little bit of initiative in that regard. And sliding scale, I mean, sliding scales aren't great. Increase the dose slowly of insulin. So if the patient is on 40 units total, so that can be basal and bolus, so that can be your Lantus and your NovaRapid, you can start increasing the correctional dose slowly, 10%, okay? So 40 units, 44 units total. If the blood sugar is very high, maybe go for 48 units. Be very toey about increasing it more than that without having someone more senior on the phone. And that's because high blood sugar in the absence of DKA and HHS is much easier to treat than a comatose patient. Cool. This is a diagram that I think I read in this. There's a girl, Sarah Knight was her name, who did the 2016 intern guidebook. Never met her. Don't know how I got the guidebook. Someone sent it to me, but this was in it, and it's great. So I just wanted to credit Sarah. Don't know if anyone knows her, but I'm using her diagram, her table. It's super straightforward. If the breakfast BSL is high, so this is for patients that are either on basal and bolus, so that's NovaRapid and Lantus, or they're on the pre-mixed stuff in the bottom category, which is mixed hard, Nova Mix. If the breakfast BSL is high, you obviously increase the nighttime insulin, and so on. You just take a photo of it if you want, but it's intuitive. I mean, you increase the insulin at the previous dose because all the insulin is fairly long acting. Even NovaRapid is, 4 to 6 hours in the body, so you increase it then. Not that important. A bit more niche. 2 different types of things that can happen with these insulin-dependent patients. One of them is man-made, which is the Somogyi effect, which is when you're giving too much insulin, and then and you wake up the next morning and you go into work, and the nurse says, "Oh, the patient's got a blood sugar of 20 again," and they're already on a big whack of insulin. And so what you need to do there is to differentiate these 2 things. One of them is, as I said, one of them is man-made too much insulin, where you get a dangerous hypo overnight, the Somogyi effect, and one of them is just like not enough insulin. They're just hypoglycemic in the morning because they've had insulin inhibition while they've been sleeping because of growth hormone and cortisol. And so you need to differentiate the 2. So the way you differentiate is you call endo, and before you do that, you get a 3 a.m., 4 a.m. blood sugar. Because if you keep giving more insulin, you're going to kill them overnight. That's it. It's super cruisy. You'll have a great year. I had a great year. I'm still having a great year. Be confident, but not too confident. And yeah, normal saline, 10 to 20% insulin adjustment if they're hypoglycemic. Just super easy. Yeah, cool. Good luck. A cup. Oh.
Hey everyone, my name's Johnson. I'm one of the interns from Alfred. Tonight I just wanted to talk a bit about a few common calls that you'll be asked to see next year. I've only got 2 pages that I'll go through for because of the time limits, but I thought that it'd be a good idea to take it back to the basics, because what I found at the beginning of this year is that in theory I knew what I should be looking for when someone's had low blood pressure or when someone was tachycardic. But then I'd get to the patient and I found that, you know, I really had no idea what to do, like what to ask for, what to write down. So hopefully you'll get some practical tips about what to do and how to document it. The first thing to say, and the most important message I want to just tell you tonight, is ask for help. Don't feel next year like, you know, it's up to you to solve everyone's problem. You know, you've got a team, escalate, ask early, because there's nothing worse than realising at the end, you know, oh shit, I don't know what I'm doing and I don't know what to do. I've got no one to ask. Make sure you escalate early. No one expects you to know everything. Make sure you get help. So we'll just go through a few pages. The way cover works is most of the time you won't know about the patient. So you'll be covering wards that you don't routinely work on. So you won't know anything about the patient before you get paged about them. So to give you an example, you're carrying around the pager and someone's, you know, up on the wards, low blood pressure, systolic 92, please review, there's the extension number, and that's all you get, you know, nothing about the patient. What you should do, so pretend you're, say, covering the surgical wards. What you should always do is, you know, pick up the phone and call the nurse who's paged you for two reasons. The first one, you know, because you let them know that you've received the page, that you're aware of the patient, and also secondly, because, you know, you want to get some information from the nurse before you even go up to the patient. Things I like to ask about over the phone are, is the patient symptomatic? What are the vital signs? Ask about all the vital signs, because that lets you triage how urgently you need to be seeing the patient and, you know, whether you need to be seeing them sooner rather than later. When you're doing the cover shift, you're just going to be slammed with, you know, 5, 10 different pages, and you need to learn how to triage the pages, who you need to go and see urgently and who you can see a bit later on. So let's say you've got this page, you've picked up the phone, you've asked the nurse for a bit of history, and you find out that it's a 60-year-old lady, she's day one post some bowel surgery for cancer. Where do you go on from there? I'm just going to take it step by step, because, you know, at the beginning of this year, I had no idea how to document any of this. So hopefully you'll find this helpful. Pick up the progress note, date and time, everything you write on, one liner about who you are. So cover intern, your surname. And I always start off my reviews with ATSP, ask to see patient about, low blood pressure, you know, 92 on 60. I like to write a one-liner about, you know, what the patient's history is, just so that everyone, you know, is on the same page. And then before you even go and assess the patient, have a flick through their medication chart, look at the OBS chart, look at, you know, write down what the relevant medications are. So when someone with low blood pressure, all the antihypertensives are going to be relevant. It's worth documenting it. Other things which are useful to just make a note of, so their investigation results. So when someone who's post-operative, you know, obviously hemoglobin's an important thing to keep an eye out for. Have they got enough blood going through the system? Are they bleeding out from an unknown source? So when someone who's post-operative, as this patient is, they've got about a 2-unit drop of hemoglobin from 130 pre-operatively to 105 post-operatively, which isn't uncommon. So that's nothing to, you know, panic about. Fluid balance is another important thing to look at. You know, you want to see if this patient's in negative or fluid balance. If they're in negative fluid balance, they're excreting more fluid than they're able to hold on to. If they're in positive balance, that sort of tells you that they're holding on to more water than they're excreting. And it gives you an idea, you know, an objective measure of what's happening with in and out fluid. And then after you go through the medication chart, the OBS chart, and the have a quick through the fluid balance, you then go up to the patient. So you're already walking into the room with all this information in your head. These are the 5 questions that I like to ask about whenever I'm, you know, paged about any patient. So I ask about chest pain, shortness of breath, palpitations, dizziness, and headache. The reason I like these questions is because it gives me a good idea about, you know, what the patient's doing clinically. It also gives me an idea about, you know, which path do I need to go down? Do I need to, you know, look a bit further into the cardiac history? Do I need to fish out for an infection? You know, is there something that I can treat, like pain, for example? clinical reviews are all about a targeted and focused history. So, you don't need to do an extensive history. It's all about getting in there and getting a focused history from the patient. With the examination, when you're asked to review someone with low blood pressure, it's all about the fluid status. So you want to know what they're, hemodynamically doing. So I always like to write down all the vital signs because once again, it tells the reader that you've, thought about what the vital signs are. It also lets you know, you're not bleeding out from somewhere, for example, because you've got good heart rate that isn't tachycardic or too tachycardic. I always like to write a one-liner about, what the patient looks like from the bedside because, it gives whoever's picking up the notes after you, who's reading the notes, what your assessment was, what the patient was, how they presented at the time. So they look well from the bedside, they look unwell, they're not unwell looking. With the fluid assessment, have a listen to the lungs, look at the JVP, make sure it's not elevated. Have a look into their mouth to see if the tongue's a bit dry. Have a look down the lower back to make sure they're not accumulating fluid. And do the same thing with the lower limbs. Make sure there's no edema creeping up the legs. In someone who's post-operative, they'll probably have an IDC in place. So have a look at what the IDC is draining and just make sure that the urine, having a look at the colour of the urine. Is it dark urine, which might indicate that they're a bit hypovolemic. After you do your history and examination, I always find it very useful, especially when I'm flicking through other patients' notes and reading through other people's reviews to write down what your overall impression is. So you've done your history, you've done the examination. What's your overall impression? It doesn't matter if it's wrong. Your thoughts are just as valid as anyone else's. But it's, it summarises your history and examination. And if someone's in a bit of a rush, they can flick right to the impression and see what your overall thinking was and what your overall assessment was. So in this particular patient, I've gone in, taken a history, had a listen to them, done a bit of a fluid assessment, and I've decided that they're asymptomatic and they're probably a bit hypovolemic because, the JVP is down and the mouth's a bit dry. So a reasonable plan might be encourage oral intake, review tomorrow's diuretics, so you'll withhold over the drug chart, and then ask the nurses to just keep a strict fluid balance to make sure that you can look at what's going in and what's going out. And then finally, sign off the note, your name, your role, page and number, so that they can get back to you if they need to. And at any point, you can ask your registrar or your consultant, if they agree with your plan. You don't have to go through all of this before you ask for help. You might get a page at, the beginning of the night and have no idea what's going on. That's fine. Go get help early rather than later. Just moving on to the second page. So pretend you're covering the gen med wards now, and this is a page you get. Someone's a bit tachycardic, please review. So once again, call the nurse back as soon as you can to get a bit of information. Is the patient symptomatic? What are the other vital signs doing? Do I need to see this patient urgently? And ask for an ECG over the phone. I find it really useful to ask for stuff early on so that by the time you make it to the wards, you've already got that information in front of you and you can already, you can have a look at what the ECG is doing. So you've got all of that information. You ask the nurse what the patient's story is. He's a 45-year-old man who's got a bit of lobar pneumonia. So documenting everything. Once again, date and time, everything you write on, a one-liner about who you are, ATSP, ask to see patient about a high heart rate, a one-liner about what the patient's admission issue is, and then I go to the medications again and I look at the relevant medications. So in someone who's got pneumonia, I want to make sure that they're on adequate antibiotic therapy. And then other medications which are worth thinking about when you're assessing someone for a high heart rate. Have they got enough pain control? Because we know that someone who's in pain will, mount a bit of a tachycardic response. So we can see that this patient's on some Targens, and that's got sort of a long-term cover. Salbutamol, so Ventolin, can also cause your heart rate to go up. So that's another important thing just to keep in the back of your mind. You know, is this high heart rate caused by medications? Is it iatrogenic? Ventolin is one of the more well-known medications to cause a high heart rate, and I've seen it when I've reviewed patients this year. When you're asked to review patients with a high heart rate, one of the useful things to have a look at are the electrolytes for two reasons. So the first one is the electrolytes, your electrolytes stabilise your cardiac membrane. And secondly, and probably more importantly, it's something you can actually do, you know, fix. So as Riley, you know, just talked about, you can replace electrolytes. So it's something active that you can be doing for patients to treat the tachycardia. You'll find when you're reading through patient notes next year that people have different shorthand and different abbreviations, and it, you know, it took me a while to figure out what all the different notation meant. So just to run through it quickly, when someone writes FBE and three numbers like that, that first number refers to the hemoglobin, that second number refers to the white cell count, and that third number refers to the platelet count. With UECs, that first number refers to the sodium, the second number refers to your potassium, and the third number refers to your chloride. CMP is a bit more self-explanatory, so that's your calcium, your magnesium, your phosphate, and people will underline usually results which are outside the normal range so that you can focus your attention to what's abnormal and what needs to be fixed. The ECG you asked for over the phone, so by the time you get to the patient, the information's already in front of you, you have a look at it, and the patient's in AF with a heart rate of about 112 beats per minute. So, you know, you've got all this information already before you've even gone into the room and assessed the patient. When you do make it to the patient and get a bit of a history from them, it's all about the targeted history, keeping it focused, you know, keep it short, keep it focused. I go through the 5 questions again. So I ask about chest pain, shortness of breath, any palpitations, headache or dizziness. And on top of those 5 generic questions that I ask about pretty much to any patient, I like to ask if they've got any pain anywhere else, because, you know, pain is something I can treat. You can give analgesia to treat pain. Ask about appetite, you know, have they been eating and drinking? Because if you haven't been eating and drinking and you're a bit dehydrated, that can cause a bit of a tachycardia as well. Ask about previous history of AF or a fast heart rate, because you know, that gives you an idea of if it's something more chronic or if it's something more acute and you might have to treat more seriously. With the examination findings, once again, I like to write down all the vital signs because it lets the reader know that you've seen the vital signs, you've read the OBS chart and you've acknowledged it. It's worth, when you're asked to review anyone who's outside of, who's within clinical review criteria for observations, it's worth taking the observation yourself. And that goes for a blood pressure, it goes for increased rest rates, it goes for tachycardia. So if someone's hypotensive, it's not about a bad idea to use the blood pressure cuff and take a manual blood pressure yourself. And the same thing goes for someone who's a bit tachycardic. You know, it's not a bad idea just to spend 15 or 30 seconds by the bedside with your hand over the pulse, just palpating it for yourself so that you're happy that they're tachycardic and, you know, that they've got an irregular heart rate. Once again, I like to write a comment about, you know, how they look overall by the bedside. It's, you know, it's a useful thing to know, like, is the patient peri-arrest or are they quite well looking? There's not much to examine in way of, you know, someone who's tachycardic, or at least I don't examine to, you know, beyond the heart and lungs. So you have a listen to the chest. They've got a pneumonia, so they've got a bit of crackles at the base, which is not, you know, unexpected. Have a listen to the heart to make sure there's no murmur or, no, you know, no added heart sounds. But beyond that, there's not too much in way of examination that I do myself. Once again, when you're finishing off your note, write down what you think the impression is, because people are going to go to that and see what you think of the patient. So in this particular patient, my impression was that they've got atrial fibrillation in the setting of a chest infection, and otherwise it's asymptomatic. In someone who's a 45-year-old man, that's not an unreasonable link to make. Under the plan, anyone who's got a tachycardia or any sort of arrhythmia, and in your post-operative patients, the general guide is to optimise the electrolytes by aiming for a potassium over 4 and a magnesium and your mag to be over 1. And you can replace that either IV or orally, depending on whether or not the patient can tolerate oral medication. Something else you might do under the plan is, encourage oral intake. Simply upping the fluid intake can help with replacing your hemodynamic status and bring down the heart rate. Obviously, in someone who's got pneumonia, you want to continue antibiotics. And it's perfectly reasonable under your plan. After you go and assess your patient, you have a chat with them, you flick through all their notes, and you might still have no idea what's going on. It's perfectly reasonable to write down in your plan that you'll discuss with the registrar and come back. Don't fall into the trap of thinking that it's your responsibility to fix everything, because it's not. And realise that you need help early and get help as soon as you can. Sign off the note. Once again, your name, your role, pager number, and that's it. Thanks very much.
Alrighty, good to see you guys again. I'm sure I've basically bumped into most of you during my time at med school. My name's Victor. I'm one of the Austin interns, and I'm going to talk to you generally about tips and advice about how to be a good intern at your core rotations, and give you some things to think about to really shine in your peers, and also make your consultants and registrars think, this guy or this girl I want to hire next year or in the future. So that's us. That's going to be you guys in a month's time. So get ready to be blinged up and get ready to enjoy yourself. And then that's you next year. These are some of my buddies. We're in the surgical team. I'm sure some of you might know Julian. He's there. And so these two are, one of them's from Adelaide, the other one's from the MDs. So, myths of internship. You're not just an intern. You are a junior doctor. You're not just a paper pusher. You are a person that has 5 years or 6 years of clinical knowledge that you have at your disposal. You're not junior to the nurses, although you should respect them and listen to what they say. You are not expected to do crazy overtime without getting paid for it. And you are allowed to voice an opinion and ask questions. So that's particularly important. Often when you're an intern, you feel as though you've just got to listen to what the registrar or what the consultant says. But if you just want to, just pose it nicely and just ask the question. It's just like, oh, should we really be giving metoprolol in a patient with COPD? Or are we sure we want to give that much insulin to a patient when they're hypokalemic? All these little things that you can sort of ask, just sort of ask them. So pose it as though you're asking a question for your knowledge, but then they'll start thinking, oh, maybe this guy's got a point and we need to think about it. So don't think you're just an intern. Some of you have already got your rotations locked in. Others are still waiting, like the Monash cohort. They're waiting for at least until December to get their selections out. Just a few suggestions. Obviously, do things that you want to do. Classic. I did stroke because I wanted to do stroke. I'm interested in that. If you do things that you might not ever do again. So I was keen to do cardiac surgery because I'm not going to become a surgeon, but cardiac surgery might be good for blood pressure management. Or if you want to do GP, cardiology might be good so you know how to do cardiac management in the outpatient setting. Rotations you should be interested in should be earlier. And the reason for that is because obviously you're zinged up for it, but also you can get references for it down the track, either as next year or in the future. You'll ask your seniors obviously about rotations between on this different hospital and holiday timing. Obviously, try and do it during the middle of the year. It will be paired with your emergency rotation. Don't be like me and my schmuck. I had to do my holiday rotation during weeks 1 and 2 of internship. I had no money, so I couldn't go anywhere. So I said, oh, I might as well get my wisdom teeth out. Worst 2 weeks, completely wasted, completely wasted. All right, emergency. Definitely, most interns think that this is the best rotation, and it is. The reason why is because you're always supervised by either by a registrar or a consultant, and you actually get to see patients. You're not just doing discharge summaries and scripts. You're seeing patients, you're seeing new patients, you're assessing them, you're trying to figure out, why has this patient come in? What are the main key issues? Does this patient need to get admitted, or this patient can go home? See a range of different things. Cat 1s, I know like you're an intern, you think, oh geez, I can't see a Cat 1, but you know, either tag along with a registrar or ask a consultant. You can hear on the bat phone, Cat 1 coming in, you're like, look, can I do that Cat 1 and can you supervise me? And often or not, the registrars and the consultants will be more than happy for you to take responsibility of a Cat 1. Other things include obstetrics, pediatrics, all the specialty things, because if you're not interested in specialty, this is probably going to be the last time you ever see it. SSU, short stay unit. It's called Gen Med Light. Often they've got a plan, they've got a process, and they've sent them to you for 24 hours of observation. It's not the best thing to do in emergency. And you should also look at your rotations when you get it, because PMCV specifically stipulate that you can only do 50% of your emergency department in short stay units. You cannot be rostered for more than that. And the reason is because it's just Gen Med. It honestly is. You're not seeing or assessing new patients. So make sure and speak, and if you ask medding more than 50%, you should be speaking to the emergency coordinator and saying, look, that's not part of the PMCV. I'm expected to be seeing new patients for getting exposure. And like, I'm not sure if you guys know Lisa, but she actually did that and she got her roster changed because of it. Regardless, when patients come to short stay, you should always see them again. Don't believe what the consultant has told you. Oh yeah, this person's just a bit of chest pain. Just do 6-hourly trop. If it's not, we'll send them home. Because then next thing you know, 6 hours later, this patient's hemodynamically unstable. They've got rip-roaring, tearing chest pain, and they've missed a thoracic aortic aneurysm, which unfortunately did happen at the Austin. So it can happen to any of you. So see the patient, just make sure the story's true, and ask a few extra questions. You will have to do shift work, unfortunately, in emergency. So obviously, the good thing is that you're usually on time. You hand over, you're out of there. And also for night shift, you got to stay busy, because otherwise you'll fall asleep and you'll basically just drink coffee, eat candy, eat food, whatever you can do to get through that night. But it's a good night, because usually there's only you and a reg, or plus or minus a resident. So it's usually good exposure. Things that I did during emergency to sort of maximize my exposure. So about the Cat 1s, I usually come in 20 minutes before handover and sort of scope out what's going on in the emergency department. And the Cat 1s that are already there, you know, they're being seen by a consultant or a reg who's about to leave. You pop in, you listen to the story, you do a few things, you maybe get a line in. You come over to handover, and then they're like, oh, who's going to take over this Cat 1? It's like, actually, I know this Cat 1. I was working with the consultant. Can I sort of continue on? And they're usually like, great, easy, done. You can do it. Go ahead. Let me know if you have any issues. Bam, that's your Cat 1 done. Auto imaging and bloods early. The moment you see the patient, review the patient, you come back, you should order your bloods and imaging, because they will take an hour or 2 to get back. And then you write your notes, then you talk to the consultant, you're already wasting time. You're not going to get these investigations back, and it's going to delay management. And this is one of the best things that I did during internship. And I wish someone told me earlier to do it, but always think more. Think of a plan before you speak to your seniors. Think of what this could be and initiate or consider plans. And I'll give you an example. This is what really sets you out for the rest of your rotations between just being a normal intern and really starting to become a junior doctor. Standard intern will see a patient 2 weeks post-ERCP, go take the history, do an examination, write your notes and speak to the consultant, and then nut out a differential diagnosis, order bloods, and enact the management. Sounds pretty reasonable, right? And look, over the first few weeks of emergency, you should do that. But then what a good intern will do, firstly, to cut time, you read CPF or scan medical records, you find out history already, you make a note of it, you see the patient, then you do the exam, then you think, what are the differential diagnoses? You order preliminary investigations, and then you talk to the consultant about the thing. You've said, I've got the 70-year-old gentleman, 2 weeks post-ERCP. He's got a bit of right upper quadrant pain and a bit of back pain. My obviously differentials will be post-ERCP complications, and also could it be pancreatitis? I've ordered an FB, UEC, CRP, CMP, and a lipase. And I think that this patient might require either an abdo ultrasound or a CT abdomen. I'm not sure. Which one do you think? And then the consultant's like, oh, yeah, that sounds about right. Yep, go ahead. No, sounds good. Beautiful. As opposed to the consultant going, could be pancreatitis, order a lipase, get some imaging done, come back in 30 minutes and tell me how things are going. It sets you apart. It shows to the consultant and the seniors that you are a doctor that can use his brain and use the knowledge, 6 years of knowledge that you guys have gotten to at least come up with something. And you may not be right some of the times, but that's how you start. And that's how we all have to start. Now, the last thing in emergency is procedural work. Try and get as much procedural work in emergency done as possible. So these are things that I did during my time. There's a whole bunch of other things that you can do. Because I'm interested in neurology, I was really keen to do lumbar punctures. So I targeted patients on triage that were young, with a headache, and with fever. And I'm just like, I presented back to the patient, I presented back to the consultant, like, oh, this is a young patient, first onset headache with a bit of neck stiffness and a fever. I think this patient needs an LP. And the consultant's like, can't exclude meningitis, go do the LP. Obviously, and same thing, like if you see on triage, someone's cut their skin, you know this person's gonna need sutures, you go see that patient, and I think this patient needs sutures. Yeah, go for it, suture. So procedures is the greatest during emergency. And obviously, yes, if you get some CPR done, that's great as well. I got to do some CPR, but unfortunately, I was so keen to do it. I was standing next to the nurse, and she got off, and I jumped on and I headbutted her. So she was Scottish, and she's like, "Oh, you fucking faggots!" I bought her coffee, and we were all good after that. All right, next, surgery. It is the most, sometimes it's the most challenging as an intern. There is a lot of paperwork, but you also get the most independence in the surgical rotation. You should come a bit early before the ward round to get all the lists and everything ready, so that in the ward round, it's rapid fire. The surgeons will come in and out and in and out. They won't stop. They won't touch the belly unless it's absolutely necessary. They won't even get the stethoscope to listen to the lungs. That's all your jobs, essentially. They'll be like, yep, this patient can go home, or order this, this, and this, and then they'll go to theater. Bang on 8 o'clock. So you need to make sure that you've compiled all the questions that you need to ask, all the bloods that need to be reviewed, and you make sure that you've got a plan for the patients before they go to theater. Because once they hit theater, they're scrubs. They can't answer questions unless it's an emergency situation. So particularly at the very beginning of your surgical rotation, you need to be able to just say, I know you got to go to theater. I understand that. Can we just quickly run through the list so we know what's going on? And you know the surgeon's going to be annoyed, but at least you know the plan. Because otherwise you're sitting around with a WhatsApp group saying, what should I do about this hemoglobin of 70? ... 3 hours later, hemoglobin of 70? Why didn't you call me? It's like, shit, man. Anyways, so after a ward round, the priorities are doing imaging, doing scripts, referrals, and discharge summaries. That's what the order should be. And obviously, you triage that depending on what's going on. Often, the surgical registers don't know anything. The surgical training program has, particularly in the metropolitan hospitals, has basically de-skilled them with any knowledge except for a scalpel. So often, what they'll say is, speak to the peri-op med-reg. And often, by the end of the rotation, I was like, fuck this, I'm just going to speak to the peri-op med-reg. And so, unless it's about fasting, DVT prophylaxis, or surgical timing or surgical complications, often you'll be better by just detouring and going straight to the perioperative medical registrar, who is supposed to look after the patients and keep them stable. Apart from obviously the ward jobs, theater time is key in surgery. Even if you don't want to do surgery, you should get into theater as much as you can. If you're rostered with 2 interns on the ward and it's light, you should literally just speak to the other intern and say, I'm really keen to go to theater today, or do you want to go to theater today? I'll hold the ward, I'll man the ward, so we can swap around next time. Because theater is key. And if you're rostered for theater, say, I'm rostered for theater, I'll be back afterwards. WhatsApp me any questions you want me to ask the surgeons in theater. Jockey, you need to make sure theater time. It is very rare, in my opinion, for you to have to go, the ward is chaos, no one can go to theater. I think that's just not the ideal thing about surgery. So you need to go to theater. Keep an eye on the lists. If it's appendicectomies, cholecystectomies, simple stuff, you should go because they're short, they're sweet, and they're interesting. Or if it's something really interesting like a hemicolectomy, or like a gastric bypass that you've never seen and you want to go to that. Bit of balance between the two. And when you're in theatre, you should be keen. Scrub in as much as you can, suture as much as you can, and next thing you know, your registrar is calling you and saying, Victor, where are you? I'm like, I'm in the ward. I need you to come do appendectomy with me. I'm like, okay. And next thing you know, he's holding the camera and you're doing the appendectomy. So I've done 3 appendectomies this year and I have no interest in surgery. So theatre time is key. And it is important to get that exposure, okay? So again, what the standard intern will do is finish the ward rounds, divide tasks with a co-intern, and then do jobs. What a good intern will do is negotiate with their co-intern, jockey for timings for going to theatre, go to theatre, get exposure in theatre, do some suturing, and then come back and help your fellow intern. Makes sense, right? That's what surgery is. You're not just a ward bitch. Sorry, all this is recorded. Okay, so clinic time. You've got 2 clinic times, outpatient clinics, where you can review patients, and then you review the patient, you do an examination, you go speak to a consultant. Easy. Pre-admission clinic, when you're expected to work these patients up for surgery. You need to take a full history, you need to do a full examination, particularly listen for murmurs, because murmurs will prohibit patients from going to theatre. I had a patient that I listened and heard a murmur, and I sent it for echo, had severe critical aortic stenosis. So he didn't end up going for colorectal surgery, he went next week for a TAVI, aortic surgery. So I was like, all right. So, important for working up patients in pre-admission clinic. Looking at ECGs, looking at imaging. This is a classic imaging ECG that you'll see in pre-admission clinic. Shout it out. Okay, so in the interest of time, what you're seeing is a right bundle branch block. What some interns will see is a right bundle branch block. What some of the other interns will also notice is that there's a component of left axis deviation. This is therefore a bifascicular block, left anterior fascicular, right bundle branch block. Interesting, makes you sound smart, has no impact on management. So anesthetics literally don't care about bifascicular blocks. So I just thought that was interesting to say. So that's all about surgery. Theatre time and exposure to consultants in clinic or theatre. That's what you're going to do to make yourself look really good, not the paperwork. Medicine, probably the hardest rotation, the most intense patient. And good Lord knows if you have to do general medicine in winter, when the flu season and the pneumonias come around. So if you can try and preference gen med, preference it outside of winter. I'm on gen med right now, I've got 9 patients. Lisa was on gen med last rotation, she had 27 patients. And I'm just like, all right, I won this one. So, a lot of unpaid overtime, unfortunately. The key to making sure gen med works well is that you need to get your discharge summaries and prescriptions done the day before. Because when you're on the ward round, which will roll ward round for anything between 3 to 6 hours, you're not going to be able to do scripts and discharge summaries. Then when the nurses come to you and saying this person's going, you're like, yep, I knew that. The script and discharge summary is already done. He can go. And you're just like, easy. Alternatively, the nurse will be like, this script needs to be done. You're like, oh shit, I'm on the ward round with a consultant. Now I've got to run off and do a script. And you're just going to be screwed. So do discharge summaries and scripts a day before you anticipate the patient to leave. And that will make sure things will go well. And at the same time, it's the same thing as I said in emergency. You need to start thinking further. You need to start thinking like a junior doctor. If there's a person with a problem, you need to think, how can I fix this problem? Or what are the differential diagnoses for these problems? Or who can I ask to get help for this problem? And how can I get this person home? Because once you start thinking like that and start thinking like a registrar, you can actually chime into the conversations with the registrar and the consultant discussing why this patient has hyponatremia. And then you'll be like, I think this patient needs a urine sodium and a urine osmolarity with a matched serum osmolality. And the consultant will be like, yeah, very good point. Yeah, I agree with that. The registrar's like, yeah, let's do that. And you're just like, I actually understand what's going on now. It makes sense. Push yourself. Think more. You're not a paper jockey. You are a doctor. You need to be able to start thinking about patients and how to manage patients. Admitting is a good rotation or a good subset of general medicine. Most of you will get 1 week of admitting patients. So the emergency department will call your reg about a patient that needs to be admitted, and then you will be asked to then admit this patient. So what you need to do is that you need to go see the patient, review all notes before you see the patient to make it easier and faster for you. And the really good things that will set you aside from other interns is the 4 questions. Number 1, what is the resus status? ask the patient or the family and make sure to clarify the resuscitation status, limitations of care. Number 2, what is the home situation? Is this person home alone? In which case, are we going to be able to discharge this person home alone? Or is this person home with a husband and a son who looks after them, and there's tons of services? Great. What are the activities of daily living? Can they clean? Can they wash themselves? Can they go to the shops? Can they go have fun with their friends in the city? And what services do they have in place? These 4 things actually make a general medical patient. All these patients are going to be 80-year-old crumbly. And if you just say, oh, this person's presented with a 2-week history of cough and pneumonia, past history of COPD, they'll be fine. But then they'll be like, oh, where's this patient from? And you're like, don't know. These are the things that will make you say, oh, this person's from home with a supportive and caring husband and a son that looks after them. He's getting home help and he's getting outpatient physiotherapy, and the GP and consultant will be like, oh, okay, so this patient could go home then. So that's what you need to do. Formulate plans, speak to the registrar after you've done the admission and you've thought of a plan. And then the registrar will agree or add stuff to you. That's basically, in the essence of time, this is exactly what we've just talked about. Confusion and hyponatremia, your reg says speak to endo. You can either pick up the phone and say, I've got a patient with confusion and hyponatremia. Endo will ask you 1,000,001 questions. Or you can reassess the patient, assess the patient's fluid status, determine if they're euvolemic hyponatremia, hypervolemic hyponatremia, and be able to talk to the endocrinologist and anticipate the questions that they've got, and say, before they ask the questions, say what you've got. I've got a euvolemic hyponatremic patient with a suspicion, and I suspect he's got SIADH because we're worried he's got lymphoma, and we've already sent off a urine osmolality and a urine sodium. And you know how I know this? We're going to just go to ETG and look it up. And you'll be like, oh, okay, well, what should I be looking for? Serum sodium. All right, let's send one of those off. Causes. Okay. What does this person have any causes? Has he got any fluoxetine? And then if not, go to up to date. Look that up. And then when you speak to the registrar, they'll be like, this person sounds pretty switched on. And you'd be surprised how much registrars speak with each other. They'll be like, oh yeah, this intern's pretty good. He works pretty hard. Or like this person just doesn't even try. Just, you know, registrars talk, and registrars talk to medical workforce when it comes around to employment time. And so they know which interns are pretty, they know they try hard, or which interns are just doing the basic minimum. Okay. Specialty rotations, you know, you've chosen the rotation. You should be able to read up on it, be interested in it, ask to present in departmental meetings, maybe do a bit of research if you're interested in that, and trying to get to know the consultants, because they're the ones that are going to do your referees in the future. They are also the ones that are going to employ you in the future if you want to go down that pathway. Rural rotations are really good. Really good. Great broad range of exposure. A general medical rural rotation could involve things like, when I was on Echuca Gen Med, they could involve things like Gen Med, obstetrics, psychiatry, pediatrics, and anything that wasn't surgical that they could manage at the hospital. So rural is a great exposure. The cost of that is that you sometimes feel like you have no idea what's going on and you have no one to ask for help with. But there's always someone to ask for help with, either by booking firstly online from the resources like UpToDate, AMH, ETG, or calling a tertiary hospital and say, look, I've got this patient with this problem. I have no idea what's going on. I've done this and done this and done this. What else should I do? Should never feel like you have no one to ask, okay? There's always someone to ask, and there's always someone to ask for help before. And the great thing about rural rotations is that you'll get as much hands-on exposure as possible. So this is one example of being able to try and push yourself and think a bit further. So this one was one of my patients, not the photo, but was one of my patients. 45-year-old gentleman, ED told me it was left periorbital cellulitis, admitted for IV fluid clots. What do you guys think this is? Yep, I hear it. Shingles. Like, you know, it doesn't cross the midline. It's in the trigeminal, the ophthalmic nerve distribution. Yes, it could be cellulitis, but could it be shingles essentially? You know? So the standard intern will just be on the ward round and say, continue IV antibiotics, review on ward round tomorrow. A good intern would review the history and examination. So this person actually had diabetes and was also on prednisolone for something or another. So he's immunosuppressed. And on examination, he does have decreased visual acuity on that side. And a fluorescein eye drop didn't show any ulcers. And so I looked on ETG, I commenced famciclovir. I spoke to the ophthalmology because on ETG it says speak to ophthalmology. So I spoke to ophthalmology and said, this is what I've got. And they'd be like, yep, okay. Continue the IV antibiotics. Get them to be reviewed in the ophthalmologists in the Echuca in a week. And then the patient was discharged the next day. Staying on the ward for a week with flucloxacillin, not getting any better, and then someone thinking, could this be shingles? So I think what I'm trying to encourage you to do as an intern is be a junior doctor and really try and think deeper. Think about your issues and think about how can I solve them, or who can I ask, or where can I get more information from? Resources are available online. It's great. And the important thing is about trying to get assessments done during your rotation. When you assess a patient, when you hand over a patient and the registrar says, yeah, that was really good, you can say, oh, can you do this assessment for me really quickly? And trust me, every hospital will have assessment forms. Austin has it. I think Monash has it, and Alfred has it. Like, you know, there's assessment forms that they're expected for you to do as an intern assessment portfolio. Don't poo-poo them, because this is what you're going to go, exactly the same as what you're doing in fifth year. This is what you're going to go with to the consultant at the end of the return and say, look, these are the procedures that I did. These are the histories and examinations that I did. This is what people thought of me. And then they're like, okay, I've got a better picture about you. Apart from the fact that, yes, I saw you in theater. I saw you doing an appendicectomy. I saw you reviewing patients. So post-internship, you need to start thinking about what you want to do a little bit. You know, don't go haywire on it, and just start thinking which stream you're interested in doing. I think someone's going to be talking more about career, so I'm not going to delve much into it. But just keep in mind that you need 2 references by the middle of the year. So your first and your second, and maybe your third rotation, you need to have 2 references. So always try and keep that in mind. Make sure to try and do something extracurricular, if not to keep your sanity, but for your CV, because you need to try and at least maintain your CV. Most of us when we went to reapply this year, you're just like, oh, I haven't done anything more. And you're just like, oh, she. But yeah, try and do something. Anyone that's worked with me as a med student remembers my little man bag. You can have a little man bag of your own if you want. This is what I've got in my little man bag because I'm interested in neurology: pen torch, tape, tendon hammer, tuning fork, Oxford's clinical handbook because it's got a Snellen's chart in it, pens and stethoscopes, lube because I was on colorectal, and the amount of PRs that you got to do. And then the registrar's like, "You got any lube?" And you're like, "Yes, I do." Have your own little kit about different things. The memorandum or the folder that people have. Some people like it, some people hate it, some people lose it. I think I lost mine on the ward today, actually. Shit, yeah, I did. Okay, it's good because you can keep PAF slips, resus forms, and other things in it, and progress notes. But again, the problem is that you lose it all the time. So it's balancing it up. Well, most interns start off with it in the beginning of the year, and then see whether or not it works for you. So make sure that internship is a great run and experience. You'll have a lot of fun, both inside the hospital and outside the hospital. Just don't forget what's the most important people and things to do for you, and make sure to maximize what you can do as an intern, because you're not a medical student anymore, you're a doctor. Thank you very much.
Hey everyone, my name's Lexi. I'm one of the interns at RMH this year. Anyway, I'll just get cracking. I'll try to get through it as soon as possible. So I'm talking about nights first up. Victor did touch on this already. This is ripped straight from like under-resourced memes for depressed teens or something ridiculous like that. Anyway, night shift does kind of suck, but you can get through it and it's doable. I'm just going to tell you basically the stuff that registrars told me, because I've done 5 weeks of night shifts in April when I was covering the Gen Med and Gen Surge and trauma wards, and then I've done a few night shifts sprinkled in my ED term. I actually just finished Friday morning. I wrote this on one of my night shifts. So basically, this is just practical stuff. Before you start night shift, you need to prepare your body clock. It's like you're flying to Europe, except way shitter. So what I do is a couple of nights before I start nights, I'll just stay up till 2, even 3 in the morning. I know someone who stays up to 6 in the morning the day before. I thought maybe that's not for me, but some people do it. Just go on Netflix and don't stop. Something another mate of mine does is they just keep their body clock normal, but then the night before they start, they have a nap in the afternoon, and that works for them. So just do whatever works for you. Then you start night shift, and this, I was having trouble making this a nice curve, so that's why it keeps going. And if you look close, it actually flicks up again at the end. Anyway, basically, the first 2 nights are the worst because you're just getting used to it. And I don't drink coffee, but I've taken a no-dose once, and it was on my first day of night shift because first night of night shift, because it's just a bit shitty. And it gets up to about night 3, and you're in the zone, kind of, body clock wise. And then often night shifts are like 10, 11-hour shifts. So even if you were doing that during the day, you're going to feel crappy by the 4th one of those in a row. Or it might be, so then you start feeling tired again. Anyway, it's just going to happen, and all of your buddies doing night shift with you are going through it as well. If you drink coffee, go for that, do it too, but maybe you try to keep it to the first half of your shift, because then the worst thing is if you get home and you're still hyped up on caffeine and then you can't get to sleep. So that's not ideal. Right, and then when you get home, what's really important is that you have breakfast or dinner, whatever you want to call it, when you get home in the morning. Otherwise, what happens is you wake up at like midday or 2 p.m. and you're starving, and then you have to get up and eat, and then you've ruined your sleep. So get home and get something in your belly. Something I also had a bit of trouble knowing what to do is during the shift, like, what do you eat? And like, there's nurses bring like 8 packets of Tim Tams, and you're like, oh, I'm awake, I deserve a treat. And so you start eating like shit. But I mean, if it's only a few nights, who cares? But bring little snacks. I never felt super hungry overnight, so I just snacked the whole time. But some people bring wraps and stuff like that, just whatever works for you. All right, so that's food. And then at daytime, your night, you've got to make sure you've got a great environment to sleep in. Because if it's light and I live across the road from a primary school, they're loud, that's annoying. So just make sure you do everything you can to make sure it's as dark as possible and as quiet as possible. So where's my next slide? Not working? Does anyone know what to do? There's this little animation is meant to pop up. Oh, there we are. Yeah. So be like the lady from Breakfast at Tiffany's and wear a really cool eye mask and then very fancy earplugs with tassels, or wear regular ones like I did. Anyway, it's not working again. What did you press? Never mind, I got it. Cool. I had a lot of free time this night shift. So that's just Audrey Hepburn remembering to eat breakfast before she goes to sleep. Okay. Right. Then on night shifts, I'm not going to talk about common pages because that's generally already been covered, but just keep patients comfortable and keep them alive. If a nurse asks you like, oh, this patient, I'm not sure about their, I don't know, what's a non-urgent issue? I don't know, they've stubbed their toe. No, that is, you can give them painkillers. A long-term issue, just feel like this is a daytime thing. The daytime team knows the patient infinitely better than you do. Plus, they have consultant registrar interns. They've got everyone dealing with it. If it can be put off to morning, put it off until morning. This is on the ward, by the way. If this is ED, then that's different. So if they're in pain, treat their pain, do that. And then if something's going seriously wrong and they need attention, then you should give them their attention. So fluid reviews are a really common thing that you need to do, especially on surge wards. You always get paged by the nursing staff saying, this patient's fasting from 6 a.m. Please prescribe them fluids. And you think, that's silly because no one drinks overnight anyway, so don't. But don't worry, nurses aren't stupid. They just want you to do it so that at 6 a.m. they can hook it up and be prepared. So that's something that happened a fair bit. Request for sleeping tablets is probably the one page that you won't get if you're uncovered during the day. And that can be tricky. So I asked the senior med reg, and her general rule is if they're over 75 or even over 70, just say no. And it can be awkward because nurses really push you and the patient really pushes you, but just say no. If they're old and you make them too drowsy, then they get up to go to the toilet, then they fall over and then they crack their head open and then you kill them. So just say no. then that's much easier. But like if they're like 40 and they're a bit aggro because they just are in for, you know, some little medical reason and they just want a good night's sleep, then you can do that. It makes them comfortable and, you know, hopefully they don't get addicted. Anyway, otherwise that's yeah, okay. Otherwise, just answer to an on-call shift like you would during the day. Right. One good thing about nights is sometimes it can be quieter than daytime shifts. So you've got time to chill out, get to know the rest of your night team, do this presentation. But a good thing to remember is when you do have free time is there's going to be probably another intern or another resident who's snowed under because they're covering all the shitty wards. So hospitals do it, but at Royal Melbourne we have an iPad that we all hold overnight, and I can click to see what the other jobs are that the other HMOs have, and I can take one off them if they need it. If the hospital has something different, you know, maybe have a WhatsApp group and message, hey, does anyone need help? I'm free. So that's something kind that you can do. Or you can just sneak off and watch TV. Okay, does anyone have questions about night shift? Cool. All right, now I'm going to talk about referrals. So the most important thing is to prepare. So there's a few things that certain specialties are always going to want to know. So there's, if they're an orthopedic reg and that's who you're calling because you're an ED and your patient's broken their arm, they're going to want to know if the patient is fasted. And I thought that to myself like it was last week, and I was like, they're going to want to know if they're fasted, and I don't know. And they're at the other end of the ward, I'll just call them anyway because I can't be bothered asking. And of course they asked, are they fasted? And I had to say that I didn't know. And then they're like, call me back when you do. And that was just a bit awkward. So just make sure you know everything that you can. Another thing that I always do is I sit down, I've got the chart, I've got their OBS, I put everything in front of me. I open up the computer, I get their blood test results, I get their ECM notes. Because if you're making like typically medical referrals, they ask the just really specific things sometimes. And if you've got all the information in front of you, it's a lot easier to say, sorry, I don't know off the top of my head, but let me just search that. I'll be 5 seconds. You call and it goes to voicemail and you've got to go do other shit. So you leave and then they call back in an hour and all that stuff is gone. But at least maybe you brushed up while you had the chance. Okay. So ISBAR is the thing that I know like we get taught sometimes of how to do handover, but I think handovers need to be a bit more fluid than ISBAR, especially the topic sentence, because depending on which registrar you're referring to, they all kind of want to know different things. So these are all things that happened to me. This was really early in the year, this one. So there's this 80-year-old crumbly man on the ward for, what's he here for? I don't know, who cares? He's on the medical ward. But then all of a sudden one day, he's 3 days into his mission and he gets abdominal pain. And so you get a CT and it shows that he's perfed his bowel somewhere. And so my registrar said, hey, Lexi, can you please call the emergency surgeon team and let them know. Anyway, so yeah, that's fine. So I called them, and surgeons are busy people. And I just started going, hey, I've got this 80-year-old man. He's here in the med ward for pneumonia. He has a background of ABCD. And they were like, I'm really busy. Can you call back after my ward round is done? Just call back in an hour. I was like, yeah, it's fine. And I hang up. And then my reg was like, did you tell them that they had a bowel perf? And I was like, oh, no. No, I didn't get to that part. So basically, if it's a surgeon, they're going to want to know what the surgical issue is first. Yes, they want to know all this other stuff because this guy probably isn't a great surgical candidate. They might not, this guy didn't get an operation. This guy died 3 days later. That's sad. But in terms of the referral, which is what we're talking about, just open with, hey, can I talk to you about this 80-year-old man with a perforated bowel? He does have a complex medical history. And I'll say, yeah. Then she said yes, and then she saw the patient. Whereas if I did it the other way, which I did first, she wasn't going to get there for a while. So you want them to come and feel the belly basically and see the patient. Because that's the other thing about making referrals is you have to have a specific question. And if you don't know it and the team says, like sometimes the surgeon, like there's a patient with abdo pain and the surgeons like get rid of everything surgical and the patient's got like a high CRP, they still don't know what's going on and they say refer to the medics. And you're like, But what do I say? And if sometimes they're busy and they just walk off, but you just run after them. I'm sorry, can you please clarify to me exactly what we're asking the medical team to do in this situation? And then that makes your referral a lot easier. Okay. This happened to me when I was in ED. 30-year-old man came off his bike. He's fractured a bunch of stuff. He's degloved his knee. You need to call several people in this situation. The trauma team, for one, the orthopods, and in RMH, plastics manages metacarpals. Anyway, plastics manage them. So that's 3 people you need to call. And with them, you know, if it's the trauma team, hey, can I talk to you about this patient, motorbike accident, multiple fractures? Yeah, sure, that's fine. With the orthopods, hey, can I talk to you about this patient that has a fracture? And then they have to listen. And then that works. Anyway, and so just bring to their attention what is most important. So I guess that's 2 sort of surgical type patients where the surgeons want to know what they have to fix. However, this is a patient, shortness of breath over 2 weeks, they've got some edema, and now they're worse, they've got a bit of chest pain. But what's important about this patient is that they have end-stage renal failure and they're on peritoneal dialysis. So this person could go to the Gen Med team, but in a tertiary hospital, they need to go under the renal team because they have peritoneal dialysis happens every night. Excuse me. And so the renal team, especially like the renal nurses, will know how to manage that far better than the Gen Med ward. So with this, instead of opening with a problem that they've got right now, I open with, hey, renal reg, can I talk to you about a person with end-stage renal failure on peritoneal dialysis? And then they have to listen. And then you tell them the rest of the story. So I guess that's mainly what I learned, is that sometimes the past history is more important in referrals, and sometimes the history of presenting complaint is more important in referrals. And the other important thing is having a specific question that you're asking them. Okay. The next thing I'm talking about is getting radiology approved. And it's basically just ISBAR again. You're telling them the story. I know someone who just, so what they do is they write down the request on a piece of paper. They give it to the radiologist and they just stand back, and if they have questions, they will just answer them. But I think most people would appreciate if you said, hey, I'm requesting X investigation for X complaint. Except now, I don't know, Royal Melbourne is pretty outdated in a lot of things, but we just got online radiology ordering, which is great, but you still have to do a pretty detailed thing. Once I ordered a liver ultrasound and I said, query liver pathology, and that's the whole thing that I put down, and it did not get accepted. So don't pretend that just because you don't have to face them, you don't have to actually put in a good referral. So this is something that, you know, chronic, like lower back pain is like a third of emergency, it feels like a lot of the time. But this person's got a few red flags. They've got subtle anesthesia and some degree of urinary retention. This person was a bit of a vague historian. Can you go to the toilet? Oh, I haven't gone in a while, I'm not sure. Anyway, you'll probably get the neurosurgeons at RMH will see this person for sure. And they will want you to get probably a CT and even an MRI of their lumbar spine. To make radiology do this, if you write down as per neurosurgery, that's your job done and they will do it. I guess if you're in smaller hospitals, they're not going to have neurosurgeons. But if you write down query cauda equina, they're going to do it. Right, but that was my trick, is put down as per neurosurgery on as many requests as possible. Okay, and these are just some other buzzwords that I've got is people who are elderly, like over 60, over 70, if they come into the emergency department with abdominal pain, then they need a CTAP because there's a likelihood of, like there's a high chance you're going to miss something that's serious. Basically, just make sure that the query is on there and specific, and then they have to do it. So if they've got renal colic, you need a CTKUB and you need to query stones. There are lots of rules in emergency department. If they're in a motorbike and the accident happens at greater than 30 kilometers an hour, then they need a CTA to rule out dissection. Same applies if they're in a car and it's over 60 kilometers an hour. And then just familiarize yourself with the Canadian/Nexus C-spine and brain rules just before you go on your emergency rotation. because then you can just say, as per the guidelines, I need this CT brain or I need this CT C-spine. If they've had a fall, landed on their head, then you can get, whoops, that's meant to say CT brain to rule out the intracranial hemorrhage, not a CTA. Excuse that typo. Okay. And with young people who you want ultrasounds for, you know, querying appendicitis and ovarian pathology is good if they're young female. And you can also just make sure you've got a specific query for biliary tree pathology if they're old and they've got like right up quadrant pain, stuff like that. So they're just, I mean, there's 1,000 different, you know, types of imaging. These are just a few things that came up really commonly that can be ordered really easily if you just query the right things. I'm also going to talk about career planning. So Victor did talk about this a fair bit already, but basically in your first year, great to do research. I didn't add a single thing to my CV this year and I had a great time. So you don't have to do it if you don't want to. I know plenty of people who just had their intern year as the first year where you get home at the end of the day and you don't have to study, and you don't have to do research. You just get home and you're actually home and it's a really nice feeling. So I've just used this year to embrace that. But you do need to think about it a little bit, especially because you've got to decide about what you're going to do the year after. I'm taking next year off. I'm going to travel and it's going to be fun, and it's fine to take a year off and do it if you want to, even if you do know what you want to do. So this is my little flow chart I made. If you do know what you want to do and you are getting that rotation in your internship, then try to, you know, make a good run of it. Suck up, well, don't be gross, but be, you know, be friendly with your consultants, get to know them, make some contacts. And just try to do a really good job. Maybe you rock up a little bit early on that shift compared to your other rotations. And then absolutely you should consider research if this is a field that you think you want to go into, because the further along you are in your medical career, the less time you have. So I've had registrars tell me that they wish they did their research, you know, in internship, because now they're doing it as a registrar to get onto the training program, and they have way less time as a registrar compared to as an intern. So if you know what you want to do and you've got some contacts, then go for it and do research, because it's probably your internship, you've got plenty of time. If you don't know what you want to do, that's also fine. We're still all babies, but have a think about what you are enjoying during the year, because you need to make at least some decision the next year. So you can do what I'm doing, which is nothing at all, or you need to choose medical, surgical, general. Some hospitals offer crit care, some hospitals offer women's, and some hospitals, or you can do the Royal Children's. So basically, it doesn't matter if you've got no idea, but have at least some mindset by the time it comes to applying for your applications, which will be like April, July, something the year after. I don't know, because I didn't apply at all. So make sure you do apply. Okay, that was a bit hectic and rushed. Does anyone have any questions?
Hi guys. Oh, yep, feel free to leave. Zach, come on. It's all right. I'm Izzy. I'm one of the Monash interns this year. Good to see everyone still here. Feel free to leave if you need to, because I know we're running over time, and I will be speaking quite quickly to try and catch up. And I know there's another Q&A session right after this. Cool. Couple of mixed topics. 1, internship is really hard. 2, common drugs. It's like 1 slide with 6 drugs on it. All good. And how not to die/cry on your first cover shift, which I didn't die, but almost cried. Okay. Same issue. There we go. Sorry about the busy slides. They're kind of just for me to know what I'm talking about. So internship is really, really hard. It's really hard, even though you've done a whole year of pre-internship, because you're also Monash graduates, because your responsibility level changes so much. It's a super steep learning curve for you. You're going from being the person that can say, sorry, I'm the med student, I'll ask one of the doctors, to being like, oh, I am the last line. I have to get this done, otherwise it won't be done. You have a mountain of tasks instead of just the one that your intern is currently giving to you. So instead of doing your one discharge summary and being like, yes, I helped the team, you've got 30 discharge summaries, 20 referrals, heaps of scripts, all of that. And triaging and then working with everyone else is also quite difficult. You feel a bit undervalued at times, unfortunately, especially at certain networks and certain rotations, because you pull a lot of extra hours to get work done. You're not being paid for it. Sometimes you get challenging personalities that you have to work with. Comes with any job, so not just internship or medicine in general. And you have to learn to deal with that. And you might find that after 10 weeks, you feel a lot better because you're with a different team member. And for some of you, this may be your first job. It's always difficult when you're entering the workplace at first, and you have to deal with some politics and just learning how to be a good member of the team. So as I'm sure you all know, there's a few simple things to counteracting the challenges of internship and the stresses that come with it. So eating well, sleeping well, exercising often, everyone knows it's good for mental health. Side of medicine is awesome, and having a strong support network to debrief with is very good as well. Unfortunately, it's the things that you don't predict and that I can't tell you tonight either, which will be the hardest for you next year. Some things that me and my friends found the most difficult this year. Not taking on the anxieties of other staff members. So if someone comes up to you from the allied health team or the nursing team and they look super, super worried, they're kind of yelling at you almost, and they're like, you need to see this patient right now. It's really difficult to not take on that anxiety yourself, but you'll learn to do it through repeat situations where you go and see the patient urgently and you're like, actually, this was a waste of my time. So you learn not to do that again. Learning the boundaries of your role and when to hand over is also quite difficult. Sometimes when you're given a job, you feel like that's your responsibility and you have to do it. But actually, as an intern, you're quite replaceable. And you can hand things over to the next person coming on, the afternoon resident, the afternoon intern, your registrar, if you have a rostered half day. It's really hard to hand back to a senior person, but try to do it anyway. You'll get fed up with the inefficiencies of the health system. If you come to Monash, welcome, but everything is still paper and nothing is connected. So good luck. As I mentioned before, you're meeting a lot of maybe big personalities, especially in your surgical rotations maybe, and this can be very difficult, but debrief lots, talk with interns who've worked with, if you find that you're clashing a lot, and see how they dealt with working with them. And one of the biggest things for myself this year was sometimes getting the feeling like you're a bit of a fraud or you're an incompetent doctor, and lots of people go through that feeling. The bottom line is you have to recognize when you're having sort of abnormal thoughts that you wouldn't normally think about yourself or the future, and debriefing again, whether that's seeking professional help or friends and family. That helps a lot. At Monash, we have an awesome mentoring program where you're matched up with a consultant, which is quite nice and usually an area that you're interested in. So my mentor's a consultant anaesthetist at the moment, and I told her, I'm finding internship quite stressful, and this was her response. That internship was actually the most stressful time of her whole career so far, which was quite nice of her to say. So there's several things. So you're transitioning from being a student to working. You have high expectations because you're all type A mainly. You want, a brilliant job. You want a lot of job satisfaction. You want a bright future. And sometimes it doesn't look that bright. You see people going through exams and stressing out about BPT things and all sorts of medical things. Don't do BPT, unless you really want to. And, lots of people adding research and things. What other extracurricular things? Oh, diploma of children's health or diploma of public health or masters and things. It's all a bit crazy. But remember that most of your cohort will be finding that it is also the most stressful time of their whole career, and the experience is almost universal for everyone. So do have fun. It's all good. All right, second topic already, great. So common drugs, there's not much explanation. You'll write it so much during your first week even that it will be ingrained in your memory very, very easily. So if you're asked to see someone for pain, your small things first and your oral tablets. So chart your paracetamol and ibuprofen. Don't refer someone to APS unless you've already started with the simple things and then you're struggling. even if your reg tells you, be like, hey, APS, can you help me out? They're like, okay, so what pain medications have you already given them? And you look at the chart, you're like, actually, we haven't even tried paracetamol yet. So do the simple things first whenever you're treating pain. Try endone for pretty much everyone. Just be careful with the little old ladies. Maybe go 2.5 to 5 milligrams for them. And put a maximum on so you know, so the nurse tells you if they need more than the maximum, you can discuss with your registrar, can they get more, or should we start them on Targin or something more long acting? Nausea and vomiting, really easy. Metoclopramide or Ondans. Ondansetron is great within the hospital because you can give it both oral and IV. It's great for people that are vomiting up tablets. Obviously you can't keep the metoclopramide down to help you with your nausea. The only bad thing is on discharge, having to think about ondansetron, it's super, super expensive, usually on a private script, so just be careful of that. Constipation, just note down those 3 things. I'm sure you'll get the slides later, so don't worry about jotting it down. The only note to make is in, I think, probably surgical patients, beware the Cloxel and Senna. A bit too stimulating for the bowel, I think, so we never charted it, but lactulose and Movicol, all good for most things. Constipation. With these ones, mostly you'll see most of them on the PRNs. It's a really good thing if you're writing up the admission meds for a patient to put something for pain, something for nausea, vomiting, something for constipation. Otherwise, you'll get lots of pages throughout your shift about, oh, come review this patient, and really the nurse could have just given them something if there was something on the PRN chart. Cover shifts. Okay, this is the main part of my talk, and I'm really grateful to Johnson who's covered a lot of it already. I had no idea going into it what it was and what it would be like. So that's why I had a horrible first cover shift, but then I got a bunch of advice, and I've just compiled a bunch of advice for you guys from different people, and it made cover shifts a lot better after my first one. So cover shifts essentially save hospitals money. Most of you won't have done one this year, which makes it really hard next year. Usually it's one doctor doing the job of about 2 to 4 doctors, and you're doing your usual job except with patients that you don't know. So it's quite difficult. You can have a super variable workload, so it depends on the nursing staff that are on and patients getting sick. You can't predict that. So although you're placing like 4 doctors sometimes, I've heard of people covering up to about 90 patients at a time. Diseases don't really stop for outside of business hours, weekends, or public holidays, which is when you'll be doing your cover shifts. So that's why they can be pretty hectic. Sorry about the busy slides. Last 2 slides, I promise. You can start zoning out and think about your questions for Q&A if you want. These will all be sent to you. So how to get through your first cover shift. So just a note to start with, no matter how bad or good you feel about your cover shift, it's usually not your fault. Even if it's a great one, it's probably not you. If it's a bad one, just think it's definitely not me. I was just slammed. Before you go on your first cover shift, I highly, highly recommend asking the previous interns exactly what they did during that cover shift. I kind of went into my first one clueless, joined the ward round because that's what the consultant encouraged me to do, wasted my whole morning doing jobs for another ward that I wasn't even covering and scribing on the ward round when the registrar could have been doing that. So, and then, yeah, ignoring all my pages. Nurses were angry with me afterwards because they were like, why didn't you respond to our pages? I was like, I don't know, I was on the ward round. Yeah, so find out, because all cover shifts will be different. You'll be covering a different set of patients. There'll be different expectations about the ward round and what your priorities are that day. You'll go to handover first thing in the morning, usually. That's a great time to put in the phone details of the registrar, who is your immediate superior that day, and also anyone floating around who's like a co-intern or co-resident. Because as Lexi said, on night shift, sometimes someone's really free, someone's super busy. It's great to be able to palm off some jobs if you're really snowed under. A great system that friends have told me about, but I haven't really done myself, is talking to the nurse in charge of the wards you're covering and just encouraging them to get their nurses to write down on the whiteboard a list of non-urgent tasks so you don't get beeps all throughout the day, and you can sort of wander leisurely between wards and just find out what are the non-urgent tasks and do them at your own pace. There'll be a lot of information coming at you, so it's really important to be organised with all of your pens and paper at Monash, with all of your forms, which is a humongous stack. and just have a system to write things down and not be too messy because you'll be handing over to the next person as well. Johnson already mentioned, I think, or actually all the guys have had great advice, but call back about important pages. So if you're worried about someone's blood pressure of 92, you want to immediately get more information so you can triage things. And cover shifts are basically all about triaging things, thinking about whether you're dealing with a deteriorating patient or something that's really, really chronic and you don't have to see during your shift at all. After writing, what I do is not try to clog up my pager because it's really hard to use those things. So I write down the job, and that way you have a copy of the phone number as well if you accidentally delete the page. Then I get rid of my page. Try and get a patient's BRADMA, so you have the UR number on hand if you need to make urgent referrals or talk to anyone about the patient. Yeah, delete the page, make sure you've got things written down and then tick them off as you go. It's quite nice for whoever pages you to know that you've received the page because paging systems are really silly and they can send it to the wrong pager and be like, oh, I've waited for you for 3 hours and you'll be like, I didn't get anything. So yeah, keep phoning back when you get pages and giving them time estimates, especially if it's a ward really far away. Just be like, yeah, I'm about half an hour away. Can someone else do a cannula in the meantime? And usually there'll be someone with cannula competency nearby that can do it before you get there. And probably the most important thing, make sure you eat and drink. Even if you're really, really busy, feed yourself, water yourself, and pee once at least. Some cover shifts, the longest one I've done is 14 hours. You got to go to the toilet.
One thing on
yeah.
I think this is second point is really cool. I know I started on gen-med cover shifts at the start of the year, and it's one thing for like your co-intern, you probably know, and you're like, yeah, well, when they say like, oh, this patient like looks a bit unwell, so we've taken some blood, if you can just chase them. I'm like, no worries, man, that's awesome. I'll do that for you. The problem is when it comes back with like an abnormal result, and you're like, fuck, do I do this?
Yep.
Clarify before they leave and say, what do you want me to do with this result? If the troponins up, what do you want me to do? If the CRP is up, what do you want me to do? Because often you as a day intern don't actually know what you're going to do.
Yeah.
And so at least you're there at the time and go, oh, that's a good point. I'll go and ask the bridge, and then you get that good feedback. Because so many times in the first month or two, because you're working with people who are incompetent as you are. And you're like, that's great, but what am I going to do with this? Otherwise, you're sitting there pondering away like this CRP is kind of like 20 years. You're like, you sit there for an hour before you get the screen up and be like, I might speak to the registrar. Get a plan about what you're going to do depending on the result. And not like, oh, if it's about the same, that's fine. Get a number. If it's above 20, it's lower than 10. Because it makes it so much easier to be like, oh yeah, it's 15, that's sweet. You don't know what you're going to do, but it's lazy.
Yep, great point. Thanks, Luke. Yeah, that's a good general point for whenever you get handed over a job, try and clarify, what do I do if I get an abnormal result? Who do I tell? What's their contact number? All right, cool. Back to the last bit of cover shifts. So I think there's 3 main things that I struggled with on my first cover shift in particular. Decision making. I was like, oh, I actually feel like a doctor for the first time. And this is the first Saturday I was working. So I'd done a week of scribing on gen med. And suddenly it's like, oh, you're the doctor, deal with this low blood pressure. I'm like, I'm the doctor? What? So what you need to do, I guess, is kind of the normal thing you do, history examination, except what you've got is already history examination in the progress notes. So look through those, look through guidelines if you're struggling. Like Victor said, there's heaps and heaps of resources. Usually the hospital subscribes to heaps of things that are nice for you. Prompt is good, difficult to search. So another person to call would be the reg, or it's hard to call a co-intern or co-resident, especially at the start of the year because no one knows what they're doing. So yeah, just go straight to the reg, get a definitive plan if you're struggling. And then triage again. Can you write home team review in the morning? It's always nice. When the workload is too much, which it can be on your particularly bad shifts, have your list of pages that you were dealing with, try and prioritize things, triage them for yourself. If people are getting anxious in your face, try to find out what the root of their anxiety is. So someone was really anxious for me to do an admission, but I was like, they have a discharge summary, like, you know what's going on. And really, at the end of the day, when I finally got around to doing it, I found out all they wanted was for me to scribe a new drug chart for them so they could sign off the drugs they were giving. So just find out what they want. Yeah, we already know, get help from nearby colleagues, let your reg know things early, eat and drink, and yeah, have a list of jobs to hand over. That's okay. It's not like a bad look for you. I mean, it's not a good look for you to have 0 jobs to hand over. It's nice for the next person, but it's kind of strange for them as well. Like, they expect to have things to do. And then if you feel really out of your depth, remember that's what the MET call system is for. It's designed as a safety net for patients. So if they're really deteriorating, they get a team seeing them that's quite senior, and they get investigations done really quickly and management done really quickly. So just let the MET calls happen. If a nurse wants to call a MET call and you feel like, yeah, you wouldn't be able to handle it yourself, that's awesome. Like, a lot of senior regs will rush to your aid immediately. If there is time and you feel out of your depth, but it's someone that's not, you know, imminently deteriorating, then look it up again and then get advice. Cool. Thanks so much for listening. I think there's a Q&A session.
Q&A session. Anyone have any questions they want to ask? Finally decided to stay, but we didn't have any to talk. Does anyone have any questions they want to ask? Yeah.
We might just sit out in front, and then you guys can just cut out questions and all that. So go out or like, I don't know, stick up your hand or whatever.
Who's going to Monash?
Woo!
No questions. Yeah.
I think yeah.
And you don't, you only have $2 grand to spend it on. What happens? You're not going to pay $11,000.
So if you say,
They give it back to you, or do they just
yes, they give it back to you. So you have to pay tax on it. So if you say take out $11,000, and they take out $11,000, and you have the receipt for $2,000, they'll give you $2,000 tax free. And then at the end of the fringe benefit tax year, March, they'll say, here you go, $9,000, pay tax on that.
If you've got nothing to buy, you save on money. Like, if you buy things, you save on tax. But you lose money if you bought them. You don't pay money by buying a car. You still have a car.
You sound a bit scorned. Sounds like experience.
Feel free to come down and ask.
Come down and ask if you have personal questions or about the hospital or anything.
Thanks so much for coming, guys.
Lexi, that was highly entertaining. This one has something in it.